Hello everyone, this is Dr. Surpi and today we'll be discussing Cushing syndrome. So Cushing syndrome, it reflects a constellation of clinical features that result from a chronic exposure to excess glucocorticoids. So it results from a chronic exposure to excess glucocorticoids of any etiology. It may be ACTH dependent or ACTH independent. Okay, so ACTH dependent means that ACTH is constantly stimulating the adrenals to produce cortisol, while ACTH independent means adrenals themselves are hyperactive and excessive cortisol is being produced from the adrenals without the effect of ACTH. Okay, so the disorders which can be ACTH dependent includes pituitary corticotrope adenoma. So pituitary corticotrope adenoma, that is pituitary producing excess ACTH that is stimulating the adrenal glands. The pituitary corticotrope adenoma is known as Cushing's disease. So Cushing syndrome and Cushing's disease, you should know what is the difference. Cushing's disease is only pituitary corticotrope adenoma, while Cushing syndrome includes all the causes of excess glucocorticoids in the body. Okay, so Cushing's disease is pituitary corticoadenoma, that is an ACTH dependent cause. Then other causes of ACTH dependent include ectopic secretion of ACTH by a non-pituitary tumor. Okay, and ACTH independent, it may include adrenal adenoma, adrenal carcinoma, and nodular adrenal hyperplasia, etc. There's another cause apart from this ACTH dependent and independent, which are endogenous causes. There may be exogenous administration of glucocorticoids leading to Cushing-like features, that is known as iatrogenic Cushings. So if exogenous and endogenous Cushings are considered together, then iatrogenic Cushings is the most common cause taken together. Cushing's disease, that is the pituitary corticotrope adenoma, it is more common in females. It is more common in females except in pre-pubertal age, where it is more common in boys. So just revising the table from Harrison. So there is an ACTH dependent Cushing's when there is an ACTH independent Cushing's. So 90% of the cases are actually ACTH dependent, out of majority 75% of the cases out of that 90% are Cushing's disease, that is the pituitary corticotrope adenoma that is producing excess of ACTH. Okay, and as we have already discussed, it is more common in females but except in the pre-pubertal age, where it is more common in boys. By contrast, the ectopic ACTH is a little more common in men. Okay, the ectopic ACTH syndrome, which is most commonly produced by carcinoids, especially the carcinoids from the lungs, from the thymus, and that of the pancreas. Okay, so these carcinoids, they are the most common cause of ectopic ACTH production. It can also be produced from small cell lung cancer and medullary carcinoma thyroid and also pheochromocytoma. So it is little more common in men, with little preponderance of men, and constitute 15% of the total cases. Okay, among the ACTH independent Cushings, it includes adrenocortical adenoma or carcinoma, and third is the macronodular adrenal hyperplasia. Fourth is PPNAD, that is primary pigmented nodular adrenal disease, and can be associated with some syndromes like Carney syndrome, can be associated with Carney syndrome, can be associated with McCune-Albright syndrome. Okay, so again, remembering overall the medical use of glucocorticoids, that is iatrogenic Cushing's, is the most common cause. Now we will discuss the various causes of ACTH dependent as well as independent Cushing's in a little more detail. First discussing the ACTH dependent Cushing's, out of which the most common cause is the Cushing's disease, that is a pituitary corticotrope adenoma. So in at least 90% of the patients with Cushing's disease, ACTH is excess, it is caused by pituitary microadenoma. Okay, that is less than 1 centimeter in size. 90% of the Cushing's disease is by pituitary microadenoma, while pituitary macroadenomas, that are tumors more than 1 centimeter in size, they are found in only 5 to 10% of the patients. Okay, pituitary corticotrope adenomas, they usually occur sporadically and are rarely found in context with multiple endocrine neoplasia type 1, MEN type 1, which is characterized by pituitary adenomas, parathyroid hyperplasia, and pancreatic tumors. 3 Ps. Okay, the 3 Ps are pituitary adenoma, remember, parathyroid, pituitary, and pancreatic. So pituitary adenomas, they sometimes occur in association with multiple endocrine neoplasias, that is MEN1. Okay. Sometimes Cushing's disease can be because of genetic alterations like sporadic mutations which occur in adults in USP8, that is a D-ubiquitinase. That is D-ubiquitinase. It is a D-ubiquitinase gene in which the mutation occurs, that is USP8, which is more common in adults, this mutation, and more common in females. Okay, so this is the cause of pituitary adenomas, which is genetic in cause, that is USP8 mutation, which is sporadically occurring in adults and more commonly in females. Okay, next cause of ACTH dependent Cushing's is ectopic ACTH production. Ectopic ACTH production, that is ACTH production other than the pituitary. So the ectopic ACTH production is predominantly caused by an occult carcinoid tumor, which is most frequently occurring in the lung, also occurs in thymus and pancreas, as I have already discussed. Okay. Now, because of their small size, these tumors are always difficult to locate, therefore they are usually occult. Sometimes they are also caused by advanced small cell carcinoma of the lung, which cause ectopic ACTH production as a paraneoplastic syndrome. Okay. So this was about the ACTH dependent Cushing's. Now coming to the ACTH independent Cushing's. So the majority of the patients with ACTH independent cortisol excess, they usually harbor adrenal adenoma. Okay, this is the most common cause of ACTH independent Cushing's. Okay, it can also occur because of mutations in the protein kinase A, that is protein kinase A subunit PRKACA. Okay, this is just a point to note. Other causes of ACTH independent include adrenal carcinoma, and it is a rare cause but also noticeable, and adrenal carcinomas may cause this excessive production of several corticosteroid classes, not only glucocorticoids. Okay, this is the point to remember. Rare but notable cause of adrenal cortisol excess is macronodular adrenal hyperplasia. Okay, and it is characterized by a low ACTH circulating level. Okay, because the nodules are hyperplastic, and these hyperplastic nodules, they are characterized by ectopic expression of G protein coupled receptors not usually found in adrenals, and these usually include LH, vasopressin, and serotonin, interleukin 1, catecholamines, GIP1. Okay, so these all receptors are which are not found in the adrenals. These hyperplastic nodules, they ectopically express these receptors also. Okay, apart from the ACTH receptors, although this have low ACTH production but excessive cortisol production, and usually the mutation that occurs is the ARMC mutation that occurs in macular adrenal hyperplasia. Okay, point to note this: out of these ectopic receptors that are expressed in macronodular pituitary adenomas, GIP overexpression, it causes food dependent Cushing, because GIP is gastric inhibitory peptide, and this is found in the GI tract and is responsible for food dependent Cushing's. Another cause of ACTH independent Cushing's is the Carney's complex. So Carney's complex, it is an autosomal dominant disorder and can characterized by multiple neoplasias. Okay, multiple neoplasias most commonly occur are cardiac myxomas. The Carney's complex, C for C. Okay, C is Carney's and C is cardiac myxomas. So Carney's complex is characterized by Cushing syndrome, CCC. Okay, Carney's complex, Cushing syndrome, which is ACTH independent and characterized by cardiac myxomas also. Okay, other neoplasias like hyperlentigenosis, Sertoli cell tumors, and PPNAD. PPNAD is primary pigmented nodular adrenal disease. So this is responsible for Cushing's. Primary, I'll write over here, primary pigmented nodular adrenal disease. Okay, this is the complex. PPNAD is found in the Carney's complex, which is responsible for Cushing's. Okay, another rare cause of ACTH independent Cushing's is McCune-Albright syndrome. It is characterized by a triad that is associated with polyostotic fibrous dysplasia, cafe au lait spots, and precocious puberty, along with Cushing syndrome. Okay, and is characterized by activating mutations in the stimulatory protein alpha. Okay, stimulatory protein alpha subunit GNAS. Okay, GNAS, that is guanosine nucleotide binding protein alpha stimulatory activity polypeptide 1. Okay, you don't need to remember the full form, but GNAS is guanosine related and guanine related, and GNAS mutation leads to McCune-Albright syndrome that is characterized by a triad, which is very important and usually asked in exams. Precocious puberty, polyostotic fibrous dysplasia, and cafe au lait spots. Okay, so these were the causes of Cushing syndrome. Next, we'll consider the manifestations, clinical manifestations of Cushing's. So glucocorticoids, they affect almost all cells of the body. All cells of the body are affected, and thus signs of cortisol excess, they impact many systems. Many physiologic systems are impacted. Okay, so the cortisol, it increases the glycogenolysis, that is increased glycogen breakdown, increased gluconeogenesis, increased glucose production in the liver, increased lipolysis, increased lipid breakdown, and increased protein catabolism and breakdown too. Okay, so excess glucocorticoid secretion, it is overcome by the ability of 11 beta hydroxysteroid dehydrogenase type 2 to rapidly, which is rapidly inactivated. The cortisol is rapidly inactivated to cortisone. Okay, so as we had already studied in our previous lecture, the cortisol in the kidney tubules, it is converted under the enzyme 11 beta hydroxysteroid dehydrogenase type 2 into cortisone. Okay, so why it needs to be deactivated? Because the cortisol, it has mineralocorticoid action also. It will act on the mineralocorticoid, MR receptors that are present in the kidney tubule. It will translocate into the nucleus. It will activate the hormone response element, which will increase the transcription of ENaC, that is epithelial sodium channels, and also increase the expression of serum glucokinase inducible kinase, that is SGK1. Okay, these two expressions are increased. The ENaC, it usually embeds with any DD4 and is inactivated, but because SGK1 is also overproduced, it will prevent the interaction of ENaC with NED4, and this complex will form, and more of embedment of this ENaC into the membrane will occur. ENaC will be incorporated more into the membrane in the presence of these changes. Okay, so because of the incorporation of epithelial sodium channels into the kidney tubule luminal side, it will cause the sodium reabsorption into the tubule. Thus, this is how the cortisol, it exerts its mineralocorticoid action by increasing the ENaC expression on the luminal side of the kidney tubule cell, and then increasing the sodium and water reabsorption, and thus exerting its mineralocorticoid action. Cortisol is converted to cortisone in the presence of this enzyme 11 beta hydroxysteroid dehydrogenase type 2. Cortisone is the inactive form. It will not exert its mineralocorticoid action. So, thus the excess glucocorticoids which they circulate in the blood, they are inactivated to cortisol in the kidneys, so that excessive sodium and water reabsorption cannot take place. But excess glucocorticoid secretion in Cushing syndrome, it overcomes the ability of 11 beta hydroxysteroid dehydrogenase type 2 to inactivate the cortisol to cortisone in the kidneys, and thus it increases the mineralocorticoid action of cortisol. Uh, by the increased mineralocorticoid action, there will be increased sodium reabsorption, therefore there will be increase in sodium and water retention, thus leading to diastolic hypertension and edema. It will also cause potassium loss, thus leading to hypokalemia, and H positive loss, thus leading to metabolic alkalosis. Thus, increased mineralocorticoid action due to excessive cortisol causes diastolic hypertension, hypokalemic metabolic alkalosis, and edema. Okay, now excess glucocorticoids also lead to suppression of the hypothalamo-pituitary axis, thus causing suppression of the gonadotropins, leading to hypogonadism and amenorrhea, and suppression of TSH secretion by the pituitary, thus causing hypothyroidism. So, diastolic hypertension, hypokalemic metabolic alkalosis, edema, hypogonadism, amenorrhea, hypothyroidism, all are features of Cushing syndrome. Next, we'll discuss the various signs and symptoms that will be divided according to the body compartments. First, discussing the body fat, there'll be a generalized weight gain with more of central obesity. There'll be more of central obesity, and rounded or moon face will be there. A fat pad on the back of the neck, that is called a buffalo hump, will be present. Okay, the skin, there'll be facial plethora, that is facial plethora will be there. Facial plethora is increased redness in both the cheeks. Skin will be thin and brittle. This is very important and a characteristic feature of Cushing's. Skin will be thin and brittle, and there'll be increased fragility, easy bruisability, increased bruising of the skin will be there. Also, another characteristic of Cushing's is the broad and purple stretch marks. The stretch marks like this, as seen in this diagram, they'll be more than 1 centimeter broad, and they'll be purplish in color, mostly present in the abdominal area because of the central obesity. There'll be increased stretching. There'll be also presence of acne. There'll also be presence of acne and hirsutism, that will be present. Third is the bone. There'll be decreased mineralization of the bone. Decreased mineralization will lead to osteopenia and osteoporosis, thus leading to increased tendency of vertebral fractures. And also, because there is decreased linear growth in the children, there will be loss of height. Vertebral fractures or compression fractures will lead to back pain, also decrease in height. Okay, fourth, there will be the muscle changes that will occur. There will be the proximal muscles that will be affected the most. Weakness of the proximal muscles of the upper arm will lead to inability to lift the arm above the head, while the weakness of the lower limb proximal muscles will lead to difficulty in climbing stairs or difficulty in getting up from a chair. Okay, so proximal myopathy is also characteristic of Cushing syndrome. Fifth is the cardiovascular system. As we have already discussed, there will be presence of increased mineralocorticoid action. Increased mineralocorticoid action will lead to diastolic hypertension. There will be presence of diastolic hypertension. Okay, and also increased potassium loss will lead to hypokalemia. Sodium water retention lead to edema. This is the thing that will be the changes present in the cardiovascular system. Sixth is the metabolism. There will be presence of metabolic alkalosis, as there will be increased mineralocorticoid action leading to increased H positive loss. Also, there will be increase in the glycogenolysis, and increase in gluconeogenesis. Increase in glycogenolysis and increase in gluconeogenesis will lead to an increase in the glucose production. Increased glucose will overcome the ability of the insulin to control blood sugar levels, thus causing glucose intolerance or diabetes. There'll be also an increase in the lipolysis, thus leading to increase in the LDLs, also increase in VLDLs, thus leading to dyslipidemia. Seventh is the reproductive system. In the reproductive system, because of the suppression of the HPA axis, there will be decrease in the gonadotropin releasing hormone, that is decrease in the gonadotropins, thus causing amenorrhea in women due to inhibition of gonadotropin release. Also there will be hypogonadism and decreased libido that will be present. The central nervous system changes will be emotional liability, irritability, depression. In some cases, cognitive defects also occur. Severe cases may be characterized by paranoid psychosis, but is rare and occurring only in severe untreated cases of Cushing. The last is the blood and immune system changes. There will be increase in the WBC count, remember, but there's decrease in the eosinophils, and there will be an increased susceptibility to infections. There will be increase in the coagulation, and thus leading to hypercoagulability state, increased chances of DVT, and increased chances of pulmonary embolism that will occur. So just discussing the most specific features, that are the more specific features of Cushing's, that is increased fragility or the increased thinning of the skin, easy bruisability, broad, that is more than 1 centimeters, purplish colored stria, and proximal myopathy. These are the more specific features of Cushing's, and these features should be looked for in order to confirm the diagnosis of Cushing's. In ectopic ACTH production, sources like carcinoid of the lung, etc., and advanced small cell carcinoma of the lung, small cell carcinoma of lung. These ectopic ACTH sources, they'll also cause increase ACTH and increase in the pro-opio-melanocortin cleavage products, thus leading to increased melanin production. Increased melanin production will lead to hyperpigmentation, especially of the knuckles, of the scar marks, and also increased pigmentation of knuckles, scar marks, and the friction areas of the skin. Okay, last I've already discussed that there will be increase in the coagulation, hypercoagulability state, leading to DVT and pulmonary embolism risk. So now discussing the diagnosis of Cushing's. Once a clinical suspicion of Cushing's has been made that there is presence of central obesity, proximal myopathy, presence of broad purplish stria, hypogonadism, amenorrhea, hirsutism, impaired glucose tolerance or diabetic state, diastolic hypertension, osteoporosis, etc. These all are features suggesting of Cushing's. If these features are present, then we should do some screening tests or confirmatory tests for the diagnosis of Cushing's. The most commonly done is 24-hour urinary cortisol. So 24-hour urinary cortisol, or the free cortisol excretion, it is increased to 3 times of the normal levels. Second is the dexamethasone overnight suppression test. Dexa overnight suppression test. Overnight suppression test in which the 1 milligram of dexa, it is given at 11 p.m. Overnight, there will be action of this dexa to suppress the cortisol production endogenously. And the morning 8 to 9 a.m., the cortisol levels are measured. Cortisol levels, if it is more than 50 nanomoles per liter, that is, they are not suppressed, cortisol levels, they remain more than 50 nanomoles, this is the diagnosis of Cushing's. Okay, this is the second test which we can do. The third test which we can do is the midnight plasma cortisol. The plasma cortisol at 12 midnight will be more than 130 nanomoles per liter, or the midnight salivary cortisol. This was the plasma cortisol. We can also measure the salivary cortisol, which will be more than 5 nanomoles per liter. The fourth is the low dose dexamethasone test, in which we give 0.5 milligrams of dexamethasone every 6 hours for 2 days, and Then measure the plasma cortisol. Plasma cortisol measured should be more than 50 nanomoles per liter for making a diagnosis of Cushing's. Although the cortisol should be normally suppressed, but in Cushing's it will remain above 50 nanomoles per liter, and that'll be a confirmatory test for the diagnosis of Cushing's. Now, if any of the four tests they come out to be positive, then we should consider the differential diagnosis of Cushing's and then measure the plasma ACTH levels. If the plasma ACTH levels are normal or high, that is more than 15 picograms per ml, we say that it is ACTH dependent Cushing's. While if the plasma ACTH is suppressed to less than 5 picograms per ml, that is, the ACTH is suppressed due to excess cortisol by feedback inhibition, then it makes a diagnosis of ACTH independent Cushing's. So one is ACTH dependent Cushing's, and second is ACTH independent Cushing's. Depending on the plasma ACTH levels less than 5 picograms per ml, that means the diagnosis is ACTH independent Cushing's, and if the ACTH is more than equivalent to 15 picograms per ml and or the plasma ACTH is normal, then it becomes ACTH dependent Cushing's. Okay, now the ACTH dependent Cushing's, as we already know, have two causes. One is the Cushing's disease, that is the pituitary corticotrope adenoma, and the other is ectopic ACTH production. Okay, so first, considering the Cushing disease, MRI pituitary, it is the investigation of choice for pituitary corticotrope adenomas. They fail to enhance on gadolinium administration on T1 weighted images of MRI. Okay, so just to make it clear that World War II, remember the mnemonic World War II. Okay, the water is white on T2 images. Okay, water is white on T2, that is CSF is white on T2 images, while the brain parenchyma is white on T1, right? And on gadolinium administration, the brain parenchyma enhances. Okay, but the pituitary adenoma, however, it fails to enhance on gadolinium administration. So MRI pituitary, it is the investigation of choice to diagnose a pituitary corticotrope adenoma, and now next step is that in all confirmed cases of ACTH dependent Cushing's, we need to differentiate the Cushing's disease from the ectopic ACTH. For that, we do number 1 the CRH test, and number 2 the high dose dexamethasone test. Okay, in the CRH test, what we do is, we know that CRH, it helps in stimulation of ACTH, and which further stimulates cortisol, okay, production. Now CRH, we give 100 micrograms of CRH, and there is an increase in the ACTH to more than 40% at 15 to 30 minutes, and then again increase in the cortisol to more than 20% at 45 to 60 minutes is the diagnostic criteria. Okay, so this is the positive CRH test if these values come. And high dose dexamethasone test, there is a cortisol suppression of more than 50% when we give 2 milligrams 6 hourly of cortisol for 2 days. The low dose dexamethasone, on the contrary, used 0.5 milligrams 6 hourly for 2 days. This high dose dexamethasone test uses 2 milligrams of dexamethasone 6 hourly for 2 days. So 2 milligrams is given and the cortisol suppression is more than 50%. If the CRH test both the CRH test, if the CRH test and high dose dexamethasone test is positive, then it is the diagnosis of Cushing's. If, however, the CRH test and high dose dexamethasone are negative, it means it is ectopic ACTH production. Okay, and equifocal results we need to further investigate by inferior petrosal sinus sampling. That is, what we do in that, we take two blood samples. One is the petrosal sinus sample and the peripheral blood sample, and when then measure the ACTH ratio, it should be more than 2 at baseline, more than 3 at 2 to 5 minutes after CRH administration of 100 micrograms IV. Okay, if it is positive, then it is diagnostic of Cushing's disease, and we do transsphenoidal surgery to remove the pituitary adenoma. And if it is negative, then we locate the ectopic ACTH source. Usually the ectopic ACTH source is located in the lungs, or it can be located in the thymus or pancreas. If it is still not locatable, if it is still occult, then what we do is a bilateral adrenalectomy is done. Okay, so we'll be revising this again in a little while. First, revising the ACTH independent Cushings. So ACTH independent Cushings, as we know, is caused by either adrenal adenoma, or it is caused by adrenal carcinoma, or can be caused by macronodular adrenal hyperplasia, in which there is hyperplastic nodules. Okay, so we do a CT adrenal, in which there is a non-enhancement of the nodules or the micronodules of the carcinoma. If there is bilateral macronodular adrenal hyperplasia, we bilaterally remove the adrenals, that is bilateral adrenalectomy. If there is a unilateral mass, then adrenal workup, tumor workup is done, and we do a unilateral removal of the adrenals. Now we'll revise the algorithm. So if the patient has clinical features that are suggestive of Cushing's, as we have already seen the clinical features, like the patient has hair thinning, presence of hirsutism, patient has mental irritability, depression, and emotional liability. Severe cases, the patient has paranoid psychosis as well, presence of acne, moon-like face, facial plethora, presence of peptic ulcers, loss of height, osteoporosis, osteopenia, menstrual disturbances, hypoglycemia, diastolic hypertension, hypokalemia, purple broad stria are present, easy bruisability, thin skin, these all, proximal myopathy, all these features, these are clinical features that are suggestive of Cushing's. If clinical features suggestive of Cushing's are present, then we should proceed towards the test to confirm diagnosis of Cushing's. So we first do the 24-hour urinary cortisol. 24-hour urinary cortisol levels, they should increase to more than 3 times the normal. They should increase to more than 3 times normal for a positive test for Cushing's. Number 2, what we do is the overnight dexamethasone suppression test, in which we give dexamethasone at 11 p.m. and then at 8 to 9 a.m. the dexamethasone, it should suppress the cortisol, but cortisol, if it is still high, that it is more than 50 nanomoles per liter, then it is suggestive of Cushing's. Third test we can do is the midnight plasma cortisol level, or we can do the salivary cortisol. Okay, the midnight plasma cortisol should be more than 130 nanomoles per liter, and the salivary cortisol should be more than 5 nanomoles salivary cortisol per liter. Okay, now what is this? What is the concept behind this? That the patients, they at 6 a.m. or early morning 5 a.m. they usually have a rise in the serum cortisol levels, and during the evening it tends to fall at around 6 to 7 p.m. the cortisol falls, and midnight then it falls, then it starts rising early morning at around 3 a.m. Okay, so this is the actual level. There should be a dip at midnight. Midnight dip should be present, but if midnight the cortisol is high, that is more than 130 nanomoles per liter, then it is suggestive of excess glucocorticoid secretion, suggestive of Cushing's. Number 4 test we can do is the low dose dexamethasone test. Low dose dexamethasone test, in which we give 0.5 mg of dexa is given 6 hourly, and for 2 days it is given, and then plasma cortisol is measured, and if it is still more than 50 nanomoles per liter, it is suggestive of Cushing's. If the cortisol is more than 50 nanomoles per liter, it is suggestive of Cushing's. These are the tests we use for the confirmation of Cushing's. Once the Cushing's is confirmed, we measure the plasma ACTH levels. If the plasma ACTH levels are more than 15 picograms per ml, it is suggestive that it is ACTH dependent Cushing's. Now, there are only two reasons of ACTH dependent Cushing's. One is the Cushing's disease. Cushing's disease is pituitary corticotrope adenoma. Okay, pituitary corticotrope adenoma. Now, pituitary corticotrope adenoma, as the pituitary adenomas, they fail to enhance following gadolinium enhancement on T1 weighted images. Therefore, we should do a pituitary MRI, which is the investigation of choice. And next, we should do the two tests. One is the CRH test, and the other is the high dose dexamethasone suppression test. If both of these tests, the CRH test, as we had discussed, we give 100 micrograms of CRH, and then we measure the ACTH levels. The ACTH levels, it should increase to more than 40% at 15 to 30 minutes after administration of 100 micrograms of CRH, while the cortisol, it should increase to more than 20% at 45 to 60 minutes of CRH administration. This is the CRH test, while the high dose dexamethasone test employs 2 milligrams dexamethasone given 6 hourly for 2 days, and then the cortisol level should not fail. It fails to suppress the cortisol, and it is confirmatory of Cushing's disease. Okay, if it is both a negative or it is inconclusive, we can do the inferior petrosal sinus sampling. Inferior petrosal sinus sampling, what we do is we measure the petrosal to the peripheral, that is blood, ACTH levels. If it is more than 2 at baseline or after 3 to 5 minutes of CRH administration, it is more than 3, then it is suggestive of if this is positive test, then it is suggestive of Cushing's disease, that is a pituitary corticotrope adenoma. So we have discussed here, if it is positive, then it is suggestive of Cushing's disease, and we should do a transsphenoidal surgery. If it is negative, then it should be an ectopic ACTH source, and we should look for the ectopic ACTH source either by doing CT MRI thorax, or we can do somatostatin or octreotide scintigraphy, and we should determine the source. If still we cannot determine the source, we should remove both the adrenals. So the treatment we have almost done. First is the ACTH dependent Cushing's, which includes the Cushing's disease. So it is the surgical removal of the pituitary adenoma through the transsphenoidal approach. For the ectopic ACTH production, we should locate the tumor. If we can locate it, then remove it. If we can't locate it, then we remove the adrenals bilaterally. Okay, and for the ACTH independent Cushing's, there is an adrenal tumor that can be benign or malignant, that we can remove it. If still not successful, we can give oral treatment of the Cushing's like methyrapone. So methyrapone is a drug that inhibits the 11 beta. Methyrapone is a drug that inhibits the 11 beta hydroxylase enzyme. So 11 beta hydroxylase enzyme is inhibited, and the conversion of 11 deoxycortisol to cortisol, it is inhibited. So thus it will decrease the cortisol production. We can start the methyrapone at a dose of 500 milligrams thrice a day, and maximum dose we can give is 6 grams. So it is a anti-Cushing's drugs that is used to suppress cortisol production by inhibiting the enzyme 11 beta hydroxylase. Another anti-mycotic, that is antifungal drug, ketoconazole, that comes in the azole group, we can give, that inhibits the step in steroidogenesis. As we can remember, in antifungal drugs, it used to prevent the conversion of lansoprazole to ergosterol. Okay, so it is actually at the cholesterol level, production level, it it is inhibiting the steroidogenesis, and ketoconazole thus helps in suppressing cortisol. It can be given at a starting dose of 200 milligrams thrice a day, and a maximum dose of 1200 milligrams can be used. Third drug is mitotane, that is a derivative of insecticide DDT, and it is also a adrenolytic agent, that is it destroys the adrenal glands and helps in thus decreasing the cortisol pathway destruction, and is usually given in a low dose of 500 to 1000 milligrams per day for a benign Cushing syndrome. Okay, so these are the oral drugs: metiropone, that inhibits 11 beta hydroxylase; ketoconazole, that is antimycotic and helps in the suppression of the initial stages of steroidogenesis; and mitotane, that is an insecticide derivative. Okay, so metiropone can be given at a dose of 500 milligrams TDS; ketoconazole can be given started at a dose of 200 milligram TDS; and mitotane given at a low dose of 500 to 1000 milligrams per day. Okay, and maximum dose of metiropone is 6 grams, maximum dose of ketoconazole is 1.2 grams, while mitotane is the only low dose of 500 to 1000 is given. Okay, also to remember that Cushing's disease, after surgical removal through transsphenoidal approach, there is chances of relapse. Okay, so chances of relapse, it occurs in significant number of patients. So in those patients, we can consider a second surgery, we can consider radiotherapy. In those patients, we can consider stereotactic surgery. Okay, stereotactic radiosurgery can be considered, in which stereotactically high intensity laser radiations can be used for removing certain parts. If still not successful, we can remove the bilateral adrenals, that is the last approach in a pituitary adenoma. Bilateral adrenalectomy can be done if the relapse is recurrent in a pituitary adenoma. Okay, so that's all in the treatment of Cushing's disease. So next we'll discuss hypertension and the JNC 8 guidelines for hypertension. And once all the causes of secondary hypertension have been discussed, then we can further go on to mineralocorticoid excess, pheochromocytoma, Addison's disease, etc. Thank you.